Yeah, it can. Hello. Hello guys, am I visible? Good evening everyone. I think there is a lag. ఈ రెండిటికే lag ఉంది. Okay guys, I am starting. If there is any lag or if you find any issue, please let me know in the comment sections, okay? Okay guys. Shall I continue? Okay, good evening guys. Now in this class, okay, we are going to mainly concentrate on the general topics. Okay, the general topics which are important for the exam for the next 2 hours will be mainly concentrating on the general topics. Okay, so having said that, this is the part 3 of our session. Now let me do it a little fast because these are the general topics which you can understand very easily. Okay, I won't go too much fast, you can understand them. Okay, if you find any difficulty, you can let me know in the comment sections. Okay, having said that, the first topic which I want to take now is the transport across the cellular membrane, transport of the substances in the cell. Okay, now how many types of transport are there? You just tell me. There are 2 types of transports, are the basic types of transport, the active transport as well as the passive transport. Okay, now first of all, let me talk about the active transport. What is this active transport, sir? There is transport of substances. The substances are getting transported. Why it is called as active transport? What does the word active mean here? Active means ATP is utilized. So if ATP is utilized in the process of transport of substances, then it is called as active transport. Simple. Okay. So active transport means ATP is utilized. Now this active transport is of how many types? See, this active transport is further divided into 2 types. Primary active transport, secondary active transport. Okay, look here, primary active transport is there, and there is one more type which is called as a secondary active transport. Primary active and secondary active. What is the difference between primary active transport and secondary active transport? Remember, for your entire life, wherever ATP is directly utilized in the transport of substances, okay, wherever the transport of substances are happening, if at that particular site, if ATP is directly involved, if the direct usage of ATP happens, then it is called as primary active transport. Okay, so what exactly I mean by primary active transport? Primary active transport means the direct use of ATP. They will ask you in your exam, which of the following is an example of primary active transport? Which transporter is an example of primary active transport? They will ask you. See, if any transporter or if any protein, if it is ending with the word ASE, ATPase, okay, see, for example, sodium potassium ATPase, proton ATPase, okay, calcium ATPase. If a transporter or if a protein, if it is ending with the word ATPase, then it is 100% example of primary active transport. And I have already taught you what exactly is primary active transport. Primary active transport are the transport where there is a direct use of ATP. And what are the examples? Sodium potassium ATPase is an example, and proton ATPase as well as calcium ATPase. Okay, calcium ATPase. So these are the examples of primary active transport. Now, here we need to discuss important points about the sodium potassium ATPase. Okay, a lot of times question has been asked about the sodium potassium ATPase. Now, let me show you, for example, this is the cell membrane, guys. Okay, imagine this is the cell membrane. Okay, now if this is the cell membrane, look here. Imagine this is the sodium potassium ATPase. Okay, imagine this is the display. Is it okay? Yeah, it's okay. So here is the sodium potassium ATPase. Normally, what the sodium potassium ATPase will do? Sodium potassium ATPase will bring 3 sodium into the cell and takes out 2 potassium out of the cell. We'll bring 3 sodium into the cell. We'll take out 2 potassium out of the cell. We know it. So the sodium potassium ATPase, by using ATP, okay, by using ATP, will help in the transport of the substances. Which substances? Sodium as well as potassium. So sodium potassium ATP is an example of active transport because ATP is directly used, okay, in the transport of substances. Now you tell me, how many subunits are there in this sodium potassium ATPase? Sir, there is alpha subunit, for example, alpha subunit, beta subunit. 2 subunits are there. And what is the coupling ratio, they will ask you. So the coupling ratio is 3:2. Okay, 3:2. 3 sodium ions. Oh, sorry. Just I made a small mistake here. No, 3 sodium ions are going out of the cell. 2 potassiums will come into the cell. Okay, that's a small mistake. So what is the coupling ratio? The coupling ratio is 3:2. 3 sodium ions are going to go out of the cell, and 2 potassium ions are going to come into the cell with the use of ATP. So now some MCQs. Sodium potassium ATPase, is it an example of primary active transport? Okay, is it a channel protein or is it a carrier protein? Guys, I hope you have already studied this in your regular classes. Normally proteins are actually 2 types: carrier proteins, channel proteins. See, the sodium potassium ATPase, just for now, trust me, it is an example of a carrier protein. Okay, MCQ. It's an example of carrier protein. It changes its shape. Okay, it changes its shape and helps in the movement of sodium as well as potassium. Sodium, potassium. So sodium potassium ATPase is not a channel. It's not an ion channel. It's a carrier protein which modulates its shape to help in the transport of the substances. Okay, it's a carrier protein. So MCQ done. Second MCQ. What is the coupling ratio of the sodium potassium ATPase? The coupling ratio is it throws 3 sodium out of the cell and brings 2 potassium into the cell. So the coupling ratio is 3:2. Done, sir. I have already asked you how many subunits are there in the sodium potassium ATPase. If you look here, it's a carrier protein. Okay, how many subunits are there? 2 subunits: alpha subunit, beta subunit. Even books there is also something called as a gamma subunit, but I don't want you to remember that. There are 2 subunits: alpha subunit, beta subunit. Okay, now out of this alpha subunit, beta subunit, the most important one, the regulatory one in the movement of the substances, sodium potassium movement, which subunit is important? Is alpha subunit. So the alpha subunit is the one which is helping in the movement of the sodium as well as potassium. Okay, for your understanding purpose. Okay, let me show you here. Imagine this is a cell membrane. Okay, let's take this as a cell membrane. Now imagine this is your alpha subunit, this is your beta subunit, alpha subunit, beta subunit. See, this alpha subunit, it is having extracellular, it's having extracellular site as well as intracellular site. There is an extracellular site, there is an intracellular site. Okay, extracellular domain as well as the intracellular domain. It is which substances will bind to the intracellular domain, which substances will bind to the extracellular domain. That's the question which was tested. So this ATP fellow, okay, ATP and sodium, they are going to bind to the alpha subunit only. Yes, alpha subunit only, but where? Intracellularly, which means you look here, a sodium molecule along with ATP. Okay, sodium and ATP, they are going to think, is everything okay? Okay, so sodium as well as ATP, they are going to bind towards the intracellular side. And who is going to bind to the extracellular side? Potassium is going to bind to the extracellular side. Okay, so this is the point which I want you to know. Now, sir, tell me, sodium potassium ATPase, it's an example of primary active transport. It's an example of carrier protein. What is the coupling ratio? 3:2. How many sites are there? Or how many subunits are there? Alpha subunit as well as beta subunit. What is the regulatory subunit? The most important subunit is the alpha subunit. So alpha subunit have how many domains? Extracellular domain as well as intracellular domain. So the intracellular domain, who is going to bind? Sodium as well as ATP are going to bind to the intracellular domain. Potassium is going to bound to the extracellular domain. Okay, these are the points which I want you to know. And if you ask me, sir, what are the important points about the beta subunit? See, the beta subunit is a site for glycosylation. See, in the beta subunit, glycosylation will happen. There are 3 sites for the glycosylation. Just remember, beta subunit is a site of glycosylation. Alpha subunit is the subunit which is regulating the movement of sodium potassium. ATP will bind to the alpha subunit intracellularly. Done. Okay, done, sir. Guys, is it everything is clear? Is everything clear, guys? Shall I go forward? Okay. Next, what are other points which I want you to know regarding the sodium potassium ATPase is the sodium potassium ATPase which is present on the cells. Okay, it's present on all our body cells. We know it's an example of primary active transport. See, the sodium potassium ATPase, it's activated because of certain hormones like thyroid hormones, the T3, T4. So the T3 and T4, the thyroid hormones, actually they will activate the sodium potassium ATPase. By activating the sodium potassium ATPase, this is actually a question. The T3 and T4, the thyroid hormones activate the sodium potassium ATPase and increases the basal metabolic rate. This was the question tested in many exams. Thyroid hormones increases the basal metabolic rate. Every student knows how thyroid hormones increases the number of sodium potassium ATPases. By increasing in the number of sodium potassium ATPases, more ATP are going to get broken down. So basal metabolic rate increases and even heat production increases. Okay, so thyroid hormones, 1 point, activates the sodium potassium ATPase channels. Next, drugs like digitalis, obein and dopamine. Remember, like DOD. Okay, digitalis, obein and dopamine. See, the first 2 drugs, the digitalis and obein, these are considered as the cardiac glycosides. What they will do on the myocardium, in the heart, this digitalis, obein and these substances, they will block. See, negative means inhibit. They will inhibit the sodium potassium ATPase. Whenever they inhibit the sodium potassium ATPase, do you know what happens? At the end of the day, because of these drugs, okay, these are the cardiac glycoside drugs. I hope you have studied this in pharmacology. Because of these drugs, intracellular calcium concentration increases. Whenever the intracellular calcium concentration increases, the inotropic effect. Inotropy or the heart contractility, the power of contraction is going to increase. Okay, so simple point, sodium potassium ATPases are going to be activated by thyroid hormones. The sodium potassium ATPases are going to be inhibited by digitalis, like digoxin, digitoxin kind of drugs, digitalis group of drugs, and obein as well as dopamine. What they will do, they increases the inotropy of the myocardium. So, next, primary active transport is completed. What is the mnemonic I have asked you to remember? If any transporter is ending with the word ATPase, then it is an example of primary active transporter, no doubt. Next, let's discuss about secondary active transport. In secondary active transport, see, energy is involved. So that's why we are calling it as active transport. Energy is involved, no doubt. But indirect usage of energy, not direct, but indirectly. Okay, so indirect use of ATP will happen. And who is providing the energy here? See, the energy for the secondary active transport is actually provided by the sodium potassium ATPases. The sodium potassium ATPases by themselves, they are example of primary active transport, no doubt. But the sodium potassium ATPases, they indirectly give the energy for secondary active transport. Okay, so in secondary active transport, what is the keyword? Indirect usage of ATP. Now, in your exam, they will ask you, what are the examples of secondary active transport? Remember, all co-transporters, symporters, antiporters are exchangers. Wherever you see these words, symporters are co-transporters. For example, see, sodium glucose co-transporter, SGLT, sodium glucose co-transporter, sodium potassium 2-chloride symporter, sodium chloride symporter. See, all are ending with the word symporters or co-transporters. So SGLT means already you know from biochemistry, sodium glucose co-transporter, sodium potassium 2-chloride symporter. They are all going together. So symporters are co-transporters and sodium chloride symporters. Okay, let me take some time and let me see how good you are. This SGLT, sodium glucose transporters are there, no? Okay, already here I have written, but anyway, this SGLT, it's have 2 types, SGLT type 1, SGLT type 2, very important in your exam. This SGLT type 1, where it is present? It's present in the intestines. Okay, SGLT type 1 is present in the intestines. SGLT type 2, it is present in the proximal convoluted tubule of the nephron. Very, very important. See, sodium glucose cotransporter type 2. In your nephrons, glucose is reabsorbed along with the sodium. MCQ. Glucose is reabsorbed along with the sodium. Okay, so that's why sodium glucose cotransporter type 2, it is present in PCT. Okay, so sodium glucose type transporter type 2, it's mainly present in the PCT. And in pharmacology, they will integrate with the pharmacology and they will ask you, so what are the drugs which will block this? Simple. Array, very simple. What are the examples of secondary active transport? So the examples of secondary active transport are the SGLTs, sodium glucose transporters. How many types of SGLTs are there? So there is SGLT type 1, SGLT type 2. Okay, now SGLT type 1, where it is present? In the intestine. In the intestine, it helps in the absorption of the glucose, SGLT type 1. And SGLT type 2, where it is present? SGLT type 2 is present in the proximal convoluted tubule. How to block this is the MCQ. See, there are drugs called as canagliflozin, dapagliflozin, empagliflozin. They are SGLT type 2 blockers. Okay, what are they? They are SGLT type 2 blockers. What they will do? They block the sodium glucose type 2 transporter in the PCT. So do you think glucose reabsorption will happen in the PCT? Glucose reabsorption in the kidneys, the PCT does not happen now. Why? Because SGLT type 2 is blocked because of canagliflozin, dapagliflozin. So there will be glycosuria or glucosuria. Okay, glucosuria is going to happen because of the usage of these drugs. The glucose is going out in the urine. So in the urine, microorganisms can grow because of by utilizing this glucose. So that can lead to urinary tract infections. So UTIs are a common side effect. Okay, UTIs are the common side effect because of the canagliflozin, dapagliflozin. Okay, they are glycosuric drugs. Is it clear, guys? Is it clear? Come on, answer my question. What is the coupling ratio of sodium potassium ATPase? The coupling ratio of sodium potassium ATP is 3:2. Sodium potassium ATP is an example of primary active transport. Sodium glucose cotransporter. The sodium glucose cotransporter SGLT, it's an example of secondary active transport. SGLT type 1 is present in intestines, SGLT type 2 is present in the nephrons, that is the proximal convoluted tubules. How to block SGLT type 2? SGLT type 2 is blocked with the help of drugs like canagliflozin as well as dapagliflozin. Okay, and okay, let me see how good you are. Have you ever heard about the sodium potassium 2 chloride symporter? It's an example of secondary active transport, no doubt. It's an example of secondary active transport, co-transporter, symporter. Where exactly it is present? The sodium potassium 2 chloride symporters, they are present in ascending limb of loop of Henle. Okay, they are present in the ascending limb of thick ascending limb of loop of Henle. Now the sodium chloride symporters, it's a transporter which is present in the distal convoluted tubule. Okay, these are two MCQs. Sodium potassium 2 chloride symporter is present in the ascending limb of loop of Henle. Sodium chloride symporter is present in the distal convoluted tubule. If you can remember, if you can integrate, see this sodium potassium 2 chloride symporter, it is going to be blocked with the help of loop diuretics. Okay, it is okay, loop diuretics. Excellent. Okay, Metroid. Yeah, it's in the loop of Henle and it's going to be blocked with loop diuretics. Can you tell me this sodium chloride symporter is going to be blocked with the help of which drug? The sodium chloride symporters which are present in the distal convoluted tubule are going to be blocked by thiazide diuretics. Okay, that's the important point which I want you to know. Okay, so loop diuretics as well as thiazide diuretics. Next, and wherever you hear this, all these antiporters as well as exchanges, most of the time, even not only symporters, this antiporters means one substance is moving in one direction, other substance is moving in opposite direction. So there is antiport, opposite movement of the substances. One is going out, other substance is coming in. This is not a co-transport, they are not going together, but antiporters. Okay, so even these antiporters, okay, like sodium calcium exchanger. Okay, this sodium calcium exchanger which is present in the myocytes. It's present in the myocytes as well as it's present in the distal convoluted tubule of the nephron. Okay, see, wherever you see this word, exchanges or antiporters, again they're example of secondary active transport. Okay, don't forget, the sodium calcium exchanger is an example of antiporter or exchanger. Short answer with this, active transport topic is completed. Primary active transport, secondary active transport. ATPases are example of primary active transport. all importers and antiporters. Then all importers, antiporters, exchangers, they're example of secondary active transport. Who will provide the energy for secondary active transport? Sodium potassium ATPases, they provide indirect energy for the secondary active transport. That. Now, after this, let's talk about the passive transport. Okay, now let's talk about the passive transport. So this passive transport, there are three types actually. But mainly the two important types which I want you to know is simple diffusion as well as facilitated diffusion. But wait, passive diffusion, passive transport. Why we are calling it as a passive transport? Passive means no energy is involved, no ATP is utilized. Directly, indirectly, no energy is involved. Okay, no ATP involved. Why no energy is involved, sir? Why energy is not getting involved? Because the substances are moving from high concentration to low concentration. So whenever a substance is moving from high concentration to low concentration, you don't need to give energy. Just by law, by nature's law, it will just move like that. Okay. So if a substance is moving from higher concentration to lower concentration across the cell, there is no need of any energy. There is no need to give any energy. So substances are moving according to the concentration gradient in passive transport. Now, the first type of passive transport which I want you to know is simple diffusion, sir. Okay. Look at this, simple diffusion. What is simple diffusion? Simple diffusion is very simple. Example, gases. Okay, so gases like carbon dioxide, oxygen, the gases are getting transported in our body, right? So gases will move from high concentration to low concentration, from high partial pressure to low partial pressure. So gases are moving in our body. So what is the transport which is used by the gases? Simple diffusion. Okay, simply a carbon dioxide molecule, it is moving from higher concentration to the lower concentration. Or an oxygen molecule, it is moving from higher concentration to the lower concentration. So gaseous exchange or gaseous transport is an example of simple diffusion. That's it. Okay, oxygen transport as well as carbon dioxide transport. Next, simple diffusion. Okay, next, facilitated diffusion. The second type of diffusion is a facilitated diffusion. But what exactly is facilitated diffusion? It is also diffusion, which means it is also passive, no need of energy. Substances are moving from higher concentration to lower concentration, no doubt. But why we are using the word facilitated? Okay, why we are using the word facilitated? Can anyone tell me why we are using the word facilitated? Why? Because yeah, substances are moving, man, but when the substance is moving from higher concentration to lower concentration, a carrier protein is involved, a carrier molecule is involved. Okay, so if there is a carrier protein or a channel protein, if it is involved in transport of substances, then it is called as facilitated diffusion. So for example, look here, a carrier protein is involved. Example is glut. Okay, glut. So glucose transporter. Now it is a glucose transporter, not SGLT. Remember, anything which ends with the word ATPase, primary active transport. SGLTs, sodium glucose, the co-transporters, example of secondary active transport. Now I am talking about GLUTs, GLUT. So glucose transporters are example of facilitated diffusion. Okay, which means, yeah, glucose molecules also move from high concentration to low concentration. Okay, glucose molecules also move from high concentration to low concentration, but for the movement of this glucose, okay, normal glucose cannot cross the cell membrane. A glucose molecule is a very big molecule, it cannot cross the cell membrane. You need to have, or you need to use a protein, like a carrier protein for the movement of glucose. Okay, so that's why these GLUTs, these glucose transporters, in biochemistry you would have GLUT1 is present in RBC and central nervous system, GLUT2, GLUT3, GLUT4, something like that. So glucose transporters are present. The glucose transporters are examples. They are examples of facilitated diffusion. One important physiology point of view I want you to know. In skeletal muscles and adipocytes. Okay, my question to you. You should answer. Okay, please answer in the comment section. In skeletal muscles as well as adipocytes, which type of glut is present? Which type of glut is present in skeletal muscles as well as in the adipocytes? Which type of glucose transporter is present? Anyone? Can anyone tell me? There is a little lag, but that's okay. Which type? Is it 1, 2, 3 or 4? It is glut. Excellent. It is GLUT, glut 4. Okay, there is glut 4. Okay, glucose transporter type 4. Now, one more important point. This glucose transporter type 4, it is dependent on what? It is actually this glucose transporter type 4, it is dependent on a hormone. Okay. So, glucose transporter type 4 is dependent on which hormone? It is insulin dependent. Insulin, excellent. Insulin dependent. Okay, insulin dependent. Okay, sir. Done. So now tell me, how many types of diffusion are there? Simple diffusion as well as facilitated diffusion. Simple diffusion means substances are moving from higher concentration to lower concentration, just like that. Okay, higher concentration to lower concentration, just like that. No need of any carrier protein, no need of any channel protein. Simply substances are moving. So that's an example of simple diffusion. What is facilitated diffusion? Facilitated diffusion means, okay, so facilitated diffusion means substances are again moving from the higher concentration to lower concentration, no doubt, but a carrier protein is involved. Next, one more type of diffusion which I want you to know, only one important point. The third type of diffusion is the non-ionic diffusion. Okay, non-ionic diffusion. So this non-ionic diffusion is happening where? It happens in the nephrons. Okay, non-ionic diffusion happens in the nephrons. And what is an example? One example I want you to know. It's the excretion of ammonium ion. Okay, see, when the ammonium, when it is having some charge, for example like NH4, it is not going to cross the cell membrane. But whenever it is NH3, it can cross the cell membrane. Okay, so I don't want you to go into that detail. Simply remember one thing, man. There are three types of diffusion: simple diffusion, facilitated diffusion, non-ionic diffusion. Non-ionic diffusion is happening in the nephrons. Okay, non-ionic diffusion example is excretion of ammonium ion. Excretion of ammonium ion is an example of non-ionic diffusion. That will be much more than enough for the rapid revision. If you remember that, enough. Okay, so active transports completed, passive transports completed. Now after this, let me discuss about osmosis. Okay, see, osmosis, it's a special type of transport for the larger substances. Yes, here also ATP is involved, no doubt. Osmosis is an example of active transport only. Okay, ATP is involved. Osmosis, yes, it's an active transport. But a bigger substances, okay, are getting transported in the form of vesicles. Now vesicles are getting formed, and these vesicles are moving out of the cell and they are coming into the cell. So osmosis, sir. Now question is, osmosis is for what mainly? Okay. Oh, sorry. Sorry guys, like I just confused the vesicular transport with osmosis. Sorry. Osmosis, it is also passive transport. I am extremely sorry. I just confused it with the vesicular transport. Yeah, vesicular transport, vesicles are going to be involved, and that's an active transport. Vesicular transport is an example of active transport. Here, the point which I want you to know is osmosis. Osmosis is also, like, passive transport. Passive transport, especially for the water. Okay, especially for the water. See, the movement of water, gases are getting transported. With an example of what gases are getting transported, and the example is simple diffusion. Gases are moving, and this gaseous movement is an example of simple diffusion, from high concentration to low concentration. Gases are moving from high to low concentration. That's an example of simple diffusion. But when I am talking about solvents, okay, when I am talking about solvents like water, we all know water will move from a low osmolarity, okay, low osmolarity to high osmolarity. That's one thing you need to know. Waters, especially the solvents, the liquids are going to move from low osmolarity to high osmolarity. Okay, that's the point which you need to know. Which means low osmolarity means what? Low osmolarity means pure water. For example, imagine there is a beaker. Okay, you should understand this. Okay, some students will have a confusion. Imagine you are having a beaker. In it, pure water is there. Pure water. Okay. Now, there is one more beaker. I have kept water inside it. But along with water now, I am adding sodium. Okay, sodium, potassium, magnesium, calcium, chlorine. All these ions I am adding. Now, what happens in the beaker number B? Okay, in the beaker number B, what happened to the osmolarity? Osmolarity increases. Now, the water is getting concentrated. Now, B is an example of, the beaker number B is an example of high solute concentration. There is high solute concentration. There is high osmolarity. Now the solutes, what they will do? The sodium, wherever there is sodium, it attracts the water. Okay, so water will move from beaker number A to beaker number B. There is a connection. Okay, if you establish a connection between them, okay, like this, because of this osmolarity, because of this osmolar gradient, it will attract the water. So now tell me, solvents are going to move according to osmosis. Okay, solvents are moving and that movement is called as the osmosis. So osmosis is going to happen from low osmolarity to high osmolarity. Okay, wherever there is high solute concentrations in the B, wherever there is high solute concentration, it attracts the water. Okay, done, sir. So osmolarity is also completed. Remember, osmosis is also completed. Osmosis is also an example of passive transport. Okay, passive transport. Done. Now after this, let's discuss about the vesicular transport, which I just got confused. Okay, so vesicular transport is an example of active transport. Okay, ATP is involved. But the bigger substances are going to be transported in the form of vesicles. Here now vesicles are getting formed. Okay, now for example, look here. See, there is formation of the vesicles. Okay. Now question to you is, how many types of vesicular transports are there? So there are mainly two types of vesicular transport. First type of vesicular transport is endocytosis. The second type of vesicular transport is exocytosis. Endocytosis means the cell is taking something into it. The cell is taking something into it. For example, look here, different types of endocytosis. For example, a cell can eat a solid particle like bacteria. A macrophage can eat a bacteria. By extending its pseudopods, it can engulf a bacteria. That's an example of phagocytosis. So phagocytosis is an example of endocytosis. It's a type of endocytosis. Phagocytosis is a type of endocytosis, right? And there is one more thing. For example, when the cell is getting dehydrated, it can take certain fluids into it from the surrounding, from the extracellular environment. It can take certain fluids into it. This is an example of penocytosis, which means cell is drinking water. Previously, cell is eating. Phagocytosis is cell eating. Penocytosis is cellular drinking. Okay, now you can clearly see here, this is a penocytosis. That's the cellular drinking from the extracellular fluids are being taken into the cell. Penocytosis. Answer. So look here, this endocytosis, how many types are there? Phagocytosis, which is nothing but cellular eating. Okay, cellular eating. And what is the penocytosis? Penocytosis is cellular drinking. Okay, cellular eating as well as cellular drinking. And there is a special type of endocytosis. Look at the third one. There is a special type of endocytosis where specially the receptors which are present on the cell membrane, okay, whenever there is no need, or whenever the cell doesn't want, or whenever the cell want to downregulate its activity. Now what the cell is doing is, please try to understand, these cell surface receptors, now they are getting internalized by forming a vesicle. See, now a vesicle is going to form. Now this vesicle is going to remove the cell surface receptors. From the cell surface, the receptors are going to be taken into the cell. And in this process, see, the cell is not eating anything. The cell is not eating anything from outside. The cell is not drinking anything from outside. But the cell surface receptors, whenever they are not needed, they will be taken into the cell. Okay, and during this process, are you able to appreciate these important, like certain important substances are getting involved? Okay, so these substances are called as the clathrins. Okay, the third type of endocytosis, here I am discussing is called as the receptor mediated endocytosis. Okay, receptor mediated endocytosis. And in receptor mediated endocytosis, which proteins are getting involved? Clathrins. So come on guys, now tell me, how many types of endocytosis are there? Sir, three types of endocytosis. Phagocytosis, cell eating, solid substances are getting into the cell. Cellular drinking, the fluids are entering into the cell from the extracellular environment. And receptor mediated endocytosis, receptors are going to be engulfed into the cell. And the substances which are involved in this process, in the receptor mediated endocytosis or clathrin mediated endocytosis, are clathrins. So done, sir. After this, now look here, this is which apparatus? you can very clearly say this is the Golgi apparatus. Okay, Golgi apparatus. Guys, is everything clear? I could not able to engage with you because there is a little lag. There is a 4-5 minutes lag is there, I think. But anyway, if you are facing any issue, you can directly post it in the comment section. Now, this is a Golgi apparatus, and this Golgi apparatus, what it is doing? So usually we know in the endoplasmic reticulum. See, in the endoplasmic reticulum, proteins are going to be synthesized. These proteins now they will undergo post-translational modifications. In the endoplasmic, they will undergo post-translational modifications and they will undergo certain foldings in the Golgi complex. Now, after the Golgi complex, see these proteins, now they are packed into the vesicles. Okay, now they are getting packed into the vesicles. Now these vesicles, see, they are example of vesicular transport or not? Yeah, they are example of vesicular transport, no doubt. So these vesicles, they are going to directly see, now these vesicles, whatever the proteins which are getting produced, whatever the neurotransmitters they are getting produced, see these are getting exocytosed out. They are going out. Okay, immediately they are going out. Such a type of exocytosis is called as constitutive exocytosis. Constitutive exocytosis means very simple. There is no storage. Okay, the cell is not storing these proteins. Proteins are getting synthesized in endoplasmic reticulum. They are going into Golgi apparatus. From the Golgi apparatus, now these proteins are getting packed into the vesicles. These vesicles are throwing the proteins out. So this type of exocytosis is called as constitutive exocytosis. Okay, constitutive, which is also called as unregulated exocytosis. And the other type is, if you look at this, now the proteins, whatever they are getting synthesized, yes, they are stored in the secretory vesicles and they are going to stay in the cell for little amount of time. They are getting stored. Whenever there is an appropriate signal, see, whenever there is a signal coming that, array, you are now needed. Whenever there is signal coming from outside, now this signal is going to let the release of this vesicle. So signal is coming and because of the signal now exocytosis is happening. So this type of exocytosis or the second type of exocytosis which I am discussing right now is called as non-constitutive exocytosis. So now simply tell me guys, how many types of exocytosis are there? There are two types of exocytosis. Okay, one is constitutive, other is non-constitutive. Two types of exocytosis. In which type of exocytosis the proteins are going to be stored? In non-constitutive or regulated. In non-constitutive or regulative exocytosis, proteins are going to be stored. Okay, don't worry, the PDF will be shared in the group. And certain questions which were asked in the previous exam. Clatharins, remember, clatharins are involved in exocytosis or endocytosis? Clatharins, receptor mediated endocytosis is an example of endocytosis, the third type of endocytosis. Now, which proteins or which substances are involved in exocytosis? Yeah, I used to remember X. X is like snake, right? Ex-boyfriend or something like that. Okay, ex-girlfriend. They're like snakes. Okay, that's why you just get rid of them. So X something reminds me of a snake. Okay, snake. So which proteins? Okay, which proteins? Or I shouldn't say proteins. Which molecules are involved in this exocytosis are snare proteins. The snare proteins include synaptobrimins and syntaxins. So synaptobrimins and syntaxins, they are involved in exocytosis. X for snake, snake for synaptobrimins, syntaxin, snare proteins. These two are snare proteins. Actually, there are 4 snare proteins, but for your exam, you need to know 2 snare proteins. That is synaptobrimins, syntaxins. Okay. Next, after this, with this, the transport across the membranes is completed. Okay. Now, after this, very quickly, in the next 15 minutes, let's complete what are the important points which you should know regarding the cell membrane. Simple. The cell membrane, it is made up of what? Sir, cell membrane is like a bilipid layer. Every student knows. Like, it's like a bilipid layer. Okay, it's a bilipid layer. Okay. So, it's a bilipid layer, sir. And there are these scientists who are Singer and Nicholson. These fellows, okay, Singer and Nicholson, these guys, they have given a model. Okay, they said that the cell membrane is like fluid and mosaics. It's like a sea of lipids. Okay, they saw the cell membrane like, and it's like a full of lipids, like a sea of lipids. Now in the sea of lipids, here and there, protein icebergs are floating. Proteins are like icebergs which are floating in the sea of lipids. So there is a sea of lipid. In the sea of lipid, these proteins are floating, sir, like icebergs. So that model which they have given is called as a fluid mosaic model. So tell me, fluid mosaic model is given by Singer and Nicholson. Okay. Now, according to this model, there is a bilipid layer. Okay, lipid C, and the icebergs are the proteins. Done. Now, from here, let's go a little fast. Now tell me, cell membrane is made up of what? Is it made up of proteins, lipids, or carbohydrates? Cell membranes are made up of all the three. So, in the cell membrane, proteins are present, lipids are present, as well as carbohydrates are present. Okay, cell membrane is made up of proteins, lipids, as well as carbohydrates. MCQ is how much percent proteins? Most of the cell membrane, the majority of the cell membrane, I should say, is proteins only. 55%. 55% of the cell membrane is actually proteins. Proteins. Lipids are just 45%. 45% lipids, 55% proteins. But what about the carbohydrate percentage? Only 3 to 5%, sir. Very little amount of carbohydrates are there. Okay. So proteins are 55%, lipids are 45%, and carbohydrate composition. Okay. The composition within the cell membrane is made up of what? Protein, lipid, as well as carbohydrate. Now look at the proteins. Some important points about the proteins. Okay. Proteins are maximum in cell membrane. Which cell membrane? In all the body cell membranes, proteins are maximum, but the highest concentration of proteins, okay, more than 55%, the maximum concentration of proteins are going to be seen in inner mitochondrial membrane. That's the best answer. In the inner mitochondrial membrane, the highest concentration of proteins is going to be seen. If you don't find this inner mitochondrial membrane, then the next best answer is going to be the presynaptic membrane. So inner mitochondrial membrane and the presynaptic membrane, they contains the highest concentration of proteins. Okay, but what is an exception? Exception is everywhere in all the cell membranes, the protein concentration is maximum, no doubt now. Okay, protein concentration is maximum. But in which cell membranes, in which area of the cell, the lipid composition, in which cell membrane, lipid composition is greater than the protein composition? It is a Schwann cell membrane. Okay, there are these cells called as Schwann cells. Okay, see, there are these cells called as Schwann cells. These Schwann cells, if you can remember, they will cause myelination in the peripheral nervous system. These Schwann cells are the cells which will cause myelination in central nervous system. In central nervous system, they will cause the myelination. Schwann cells will cause the myelination in the central nervous system. Now, in the Schwann cell membrane, if you look at the Schwann cell membrane, what it is doing? It's causing myelination, right? Myelination is nothing but the lipids. So, in Schwann cell membrane, there is highest concentration of lipids when compared to proteins. Everywhere it is proteins, but in Schwann cell membrane, lipids are greater. 80% is lipids, only 20% is proteins. 80 is to 20. Okay, 80 is to 20. So exceptions are also completed. Highest concentration of proteins is going to be seen in the intermitochondrial membrane, If not intermitochondrial membrane, presynaptic membrane. Then the least concentration of the proteins is going to be seen in the Schwann cell membrane. Schwann cells are the myelinating cells for the peripheral nervous system. Done, sir. Now after this, let's talk about the lipids. Okay, lipids. Now the lipids are divided into how many types? Okay, so these lipids in the cell membrane are there. No, yes, they are 55%. Okay, but these lipids, they are divided into phospholipids, glycolipids, cholesterol. There are different types of lipids, but majority type of lipid. MCQ. Which type of lipid is present in the cell membrane? Maximum, majority. It is the phospholipids. Phospholipids are the major lipids. Even glycolipids are there. Cholesterol is there, but not the triglyceride. In the cell membranes, triglycerides are absent. MCQ. In the cell membrane, triglycerides are absent. The major lipid in the cell membrane is a phospholipid. There are different types of phospholipids. Phosphatidylcholine, phosphatidyl inositol, different types. Sphingomyelin, different types are there. But remember, phospholipids are the major lipids. Triglycerides are absent. One type of lipid which is called as a cholesterol. Even cholesterol is a lipid, right? The cholesterol which is present in the cell membrane acts like a fluidity buffer. MCQ. Which substance in the cell membrane acts like a fluidity? Fluidity means the flexibility of the cell membrane. Remember it like that. Okay, the cell membrane is not getting tough, like the flexibility or the fluidity nature. The fluidity nature of the cell membrane, it will be controlled by, it's going to be buffered by which molecule? Cholesterol. So cholesterols are considered as the fluidity buffers. Okay, and last, carbohydrates. Carbohydrate concentration within the cell membrane is very least, just 3 to 5%. 3 to 5% is the carbohydrates. Okay, then so these are some basic points about the cell membrane. Now after this, let's talk about the proteins in the cell membrane. So what are the different types of proteins? Take a deep breath. We're going a little fast, so your brain needs some oxygen, okay, to synthesize the ATP and to make you to keep you awake. Okay, this is actually time you will go to sleep, right? Yeah, of course we had these classes in some little odd time. Now proteins. The proteins in the cell membrane. First point, proteins composition of how much? 55% of the cell membrane is proteins. 55% of the cell membranes are proteins. The proteins in the cell membrane are divided into integral proteins, peripheral proteins, are lipid anchored proteins. Integral proteins, peripheral proteins, and lipid anchored proteins. 3 types of proteins are there. You can ask me, what the hell are these, sir? What is the integral protein? Like, look here. Okay, the membrane proteins, here I am showing you, are a simple. If you are having a protein, see, it is spanning this protein, it is spanning from in to out. From outside, imagine, okay, this is the outside, this is the inside. Okay, outside as well as inside. If a protein is present or it's penetrating through the cell membrane, okay, partially or completely, then it is called as integral protein. Okay, integral proteins are present within the cell membrane, they are penetrating the cell membrane. If it penetrates from outside to inside, then it is called as a transmembrane protein. Means a transmembrane means throughout the membrane. Okay, transmembrane protein. So the point which I want you to know is, look here, there is this protein. It's an example of integral protein, and it is going from out to in. So I can call it as a transmembrane protein. Okay, but look here, there is one more protein. It is penetrating the cell membrane. Yes, it is penetrating, but this is an integral protein but not a transmembrane protein. Okay, image based questions you might get in upcoming next exams. Okay, but for this batch, okay, I hope you should never see the next exam. Okay, whoever are watching for the upcoming FMGE exam, I don't want you to have an experience of the next exam. Why unnecessary to take the risks? So now so integral proteins, yeah, they can be transmembrane or they can be just integral proteins but not the transmembrane. Okay, now other proteins which I want you to know is, for example, look here, there is a protein which is attached on one side, either outside or it can be either inside. It can be present on either sides. But here I am showing, for example, outside. There is a protein which is present only on the outside. It is not penetrating. It's not penetrating. Okay, so this is an example of peripheral membrane proteins. So how many types of proteins do you know? There is an integral protein, peripheral protein, integral, peripheral, and there is one more protein. See, look here. It is also like looking like peripheral, but it is having bonds. Okay, it's having bonds. Like, covalent bonds are going to be present. Okay, so this is having bonds with the lipids tightly. So these are called as lipid anchored proteins. Okay, so now come on guys, tell me how many types of proteins do you know? Integral proteins, peripheral membrane proteins, as well as the lipid anchored proteins. Now the question which was asked in one of the exam is integral protein. Okay, integral protein or transmembrane protein, you know it. See, imagine this is the cell membrane. Okay, this is the cell membrane. Now this is the protein. It is present outside as well as inside. Surrounding it is the lipids. Everywhere there are lipids, and here is a protein like this. So what is the kind of forces? How this protein is actually staying here? There should be some force, right, to keep it there. So what are the forces? The forces with which these integral proteins are existing with the surrounding lipids. What are the kind of forces which is present between the integral protein as well as the lipids? It is hydrophobic forces. Okay, that's the question. So hydrophobic forces as well as the van der Waals forces. So these hydrophobic forces and van der Waals forces are there for the integral proteins, in between the integral proteins as well as the lipids. That's the MCQ. Hydrophobic forces as well as the van der Waals forces. And what are the kinds of forces which are there for peripheral proteins and lipid anchored proteins? No need. There will be covalent bonds, electrostatic forces will be there, non-covalent forces will be there. I don't want you to remember all that. Hydrogen bonds will be there. Simple. This is the MCQ. Okay. Integral proteins and lipids. In between, okay, let me show you here. This is an integral protein. No, this is an integral protein. In between the integral protein and the surrounding lipids, what kind of forces are there? Hydrophobic forces. Okay, as well as van der Waals forces are present. Done. After this, classically in your exam, what they will ask you? Which of the following are example of integral proteins? The examples of integral proteins are the 7-pass receptor, serpentine receptors, you know, right? There is this one receptor which is passing through the cell membrane 7 times. So the 7-pass receptors or serpentine receptors are example of transmembrane receptors or integral receptors. And all the channels, okay, all the channels, even the carrier proteins. Okay, don't forget about the carrier, sodium, potassium, ATPase, channels like sodium, potassium, voltage gated sodium channel, voltage gated calcium channel, all the channels. So channels are example of integral proteins, transmembrane proteins. Carriers like sodium, potassium, ATPase, they're example of integral proteins or transmembrane proteins. Done, sir. After this, what are the examples of peripheral proteins? Peripheral proteins, they are either present outside or they are present inside. That's it. Okay, so these peripheral proteins, 3 important peripheral proteins which I want you to know. In a cell, especially in RBC, there is a protein called as pectin and ankyrin. So this pectin and ankyrin, they are responsible for biconcave. Okay, they are responsible for what? They are responsible for biconcave shape of RBC. They are giving biconcave shape to the RBC. Okay, but whenever there is a mutation in this pectin or ankyrin, pectin gap, because of some gene mutation, pectin is not there. Whenever there is pectin not present, do you think RBC is going to maintain its biconcave shape? No. So RBC now will become elliptical. So there will be hereditary elliptocytosis. The patient is going to have hereditary elliptocytosis. So pectin defect will cause hereditary elliptocytosis. Ankyrin defect is going to cause hereditary spherocytosis. Hereditary elliptocytosis, hereditary spherocytosis. Done, sir. And one more peripheral protein. Remember, this is a peripheral protein. You should know it's not an integral protein. It's not a lipid anchored protein. It's a peripheral protein. What is this? Dystrophin. Where it is present? It's present in the skeletal muscles. It's present in skeletal muscles. See, this dystrophin which is present in the skeletal muscles, whenever it is defective, it's going to cause a condition called as a DMD, Duchenne's muscular dystrophy. Duchenne's muscular dystrophy. Okay, so this Duchenne's muscular dystrophy is due to a defect, or I shouldn't say defect, absent, complete absence. This is MCQ. The complete absence of this protein which is called as the dystrophin. This dystrophin absence can lead to a disease called as the Duchenne's muscular dystrophy. Let me tell you. This dystrophin is there, right? Where it is present? It's present in the skeletal muscle. It actually gives the tensile strength to the myocyte. It's actually present in the cell membrane. It gives the tensile strength to the myocytes. But whenever this dystrophin is gone, do you think muscles will work normally? Do you think proper muscle contraction, the muscles are going to be working normally? Definitely not. The muscles are going to be weaker. Because of that, if you ask this fellow, for example, here right now I am showing you this guy who is suffering with the Duchenne's muscular dystrophy. Dystrophin gone. Dystrophin is not there. He cannot have a proper muscular activity. His muscles are very weak. So if you ask this person to squat down, and if you ask this person to just raise his body, he cannot do it just with his thigh muscles or leg muscles. He will take the supports of the upper extremities like this, like a frog, and he will stand up. Okay, so the sign is called as a Gower sign. The Gower sign is going to be positive. This is the exact question which was asked in the previous FMGE exam. Okay, in the previous FMGE exam, this question is Gower sign is positive in Duchenne's muscular dystrophy. Which protein is the defective? This was the question asked. They gave the symptom, Gower sign, and they asked which protein is defective. Peripheral protein is defective. Which peripheral protein? Dystrophin is defective. Okay, and just I'm trying to integrate. Whenever a person is having this Duchenne's muscular dystrophy, Gower sign is positive. You have seen the Gower sign. And not only that, these patients will have the pseudo calf hypertrophy. If you look at their calf muscles, it's going to be very big in size. It's actually not a calf muscle, it's the fat accumulation. That's why we use the word pseudo calf hypertrophy. Why? Because the muscles are getting totally damaged, and in the place of muscles, fat is getting accumulated. So that's why pseudo-cough hypertrophy. Okay, and what is the most common cause of death? The most common cause of death is going to be respiratory distress. The skeletal muscle, the diaphragm is not going to work properly. That can lead to respiratory distress. These patients will die. Okay, so Gover sign is going to be positive, pseudo-cough hypertrophy is going to be seen, and most common cause of death is going to be respiratory distress. And one more thing, especially it will come in physiology as well as biochemistry. See, dystrophin have the largest gene. Okay, the largest gene in the human genome. The largest gene in the human genome is therefore dystrophin. Done, sir. Now, what is the third type of protein? The third type of protein which I want you to know is a lipid anchored protein. An example of this is the GPI. GPI is a protein which is an example of lipid anchored protein. Okay, GPI is a lipid anchored protein. Remember, GPI is a lipid anchored protein. If there is absence of this lipid anchored protein, gone, this lipid anchored protein is gone, it is going to cause which disease? If this lipid anchored protein, if this GPI is not present on your cells, especially RBCs, WBCs, platelets, if it is not there, then it is going to cause a condition called as paroxysmal nocturnal hemoglobinuria. I don't want to go in detail. If I go, it will take a lot of time. Simple. Absence of a lipid anchored protein called as a GPI will cause PNH, paroxysmal nocturnal hemoglobinuria. So with that, cell membrane, the basic things, what and all you need to know about the lipids as well as the proteins are completed. After that, let's talk about this cytoskeleton. Okay, now take a deep breath. Okay, so hope you can understand everything. Your exam is also coming closer. Yeah, excellent. Atkinson, Rani, yes, it is a CD55 as well as CD59 which are called as a DAF and MIRL. Okay, DAF and MIRL which are actually present on the cell membrane surface, they are not present because GPI is not present, so DAF and MIRL are not present. So whenever the complements are activated, that will cause paroxysmal nocturnal hemoglobinuria. I don't want to go into that pathological aspect now. Simple, GPI absent causes paroxysmal nocturnal hemoglobinuria. That's it. That's it. After that, let's talk about the cytoskeleton. What is the function of cytoskeleton? The cytoskeleton maintains the shape and structure. Okay. Yes, Pygajin, yes, you are absolutely true. Okay, you're true. So, cytoskeleton is the one which helps in shape of the cell, maintenance of the shape of the cell. What are coming under the cytoskeleton? Okay, which molecules are coming under the cytoskeleton? See, the cytoskeleton includes microtubules, microfilaments, okay, microfilaments as well as intermediate filaments. So, microtubules, microfilaments as well as the intermediate filaments. Now, remember, these microtubules and microfilaments, they are considered as dynamic cytoskeleton. Okay, they are considered as a dynamic cytoskeleton. Why? Because they will change. Okay, they will change. Okay, so they will change the shape with the time. They will undergo polymerization. They will undergo depolymerization. So the length of microtubules and microfilaments is not going to be constant. They will change with the time. So that's why dynamic cytoskeleton means dynamic means change, right? So microtubules and microfilaments are example of dynamic cytoskeleton. And these intermediary filaments, once they are there, they are not going to grow. So it's an example of static cytoskeleton. Okay, static. With the time, it won't grow. So now come, just tell me, cytoskeleton, it includes microtubules, microfilaments as well as intermediary filaments. Answer. Next. Out of this microtubules, microfilaments and intermediate filaments, what are the strongest? The strongest cytoskeleton is microtubules. Okay, strongest is the microtubules. These microtubules consist of what? These microtubules made up of what? Look here, these microtubules are actually made up of dyneins, kinesin and tubulins. So dyneins, kinesins and tubulins, they are a part of, okay, they are all a part of microtubules. You look here, for example, here I am showing you. See, these are all tubulin molecules. Okay, these are all tubulin molecules. Now, all these tubulin molecules, they are arranging. Okay, they are arranging in concentric rings and they are forming a microtubule. So microtubule is made up of this tubulins, okay. And not only that, are you able to appreciate this kinesin as well as this dynein? So dynein, kinesin as well as this tubulin. Okay, this tubulins. So this tubulin, dynein and kinesin, all of them together they forms the microtubules. Okay. Now here what are the important points I want you to know is regarding this dynein and kinesin. Okay, dynein and kinesin. As seen, especially this is something important in neurons, nerves. Okay. I have already taught you. Okay, I have already taught you. This microtubules an example of a dynamic cytoskeleton, which means they will grow or they will shrink. This tubule can grow and it can shrink. So whenever, for example, imagine this is a microtubule. Okay, this is a microtubule made up of tubulin. Whenever new tubulin molecules are getting added, so this is called as polymerization, right? Whenever the new tubulin molecules are getting added, the polymerization is happening. So growth is happening. So this end is considered as a positive terminus. Okay, this end is called as a positive terminus where polymerization of new tubulin molecules are happening and growth is happening. Positive side. Okay, and the other end is called as a negative end. Okay, positive as well as a negative end. So now you know, see there is a positive side as well as a negative side. Now you look here. Let's take this as a neuron. Okay, now let's consider this as a neuron. And what is this? This is an axon. Okay, here is a nerve terminal. Now, look here. Here is tubulin. For example, microtubule is there. Okay, here is a microtubule. Now, one side is considered as a positive side, other side is considered as a negative side. Okay. Now here the neurotransmitters are getting synthesized. The neurotransmitters are synthesized. Okay, I'm going a little fast now. See, the neurotransmitters are going to be synthesized in the cell body. This is the cell body, right? Cell body is the area where the neurotransmitters are going to be synthesized. So all these neurotransmitters are going to be captured in a vesicle. They are going to be filled in a vesicle. Now you should know very interesting thing. Look at this dynein. So what this dynein will do is, dynein, it will help in retrograde cargo. Dynein will help in retrograde cargo. And this kinesin, it will help in anterograde cargo. Anterograde cargo and retrograde cargo. What exactly are this anterograde and retrograde cargo? Normally, see, okay, see, this is a dynein molecule. It is helping in what? It is helping in anterograde movement, which means the vesicle, see the vesicle, it is moving from positive side to negative side. Okay, so if a vesicle with the help of this dynein, actually imagine I am a dynein, okay, I am a dynein, I am holding this, okay, I am holding this, I am taking this vesicle, okay, the vesicle is containing the neurotransmitter, so the vesicular transport is happening with the help of this dynein from plus side to minus side. Okay, from plus side to minus side, this is called as the anterograde cargo. Okay, anterograde cargo. Only what they will ask in the exam is simple. Anterograde cargo. Which molecule is getting involved? Which microtubular molecule is getting involved? Dynein. And kinesin. Okay, so kinesin, it is involved in retrograde cargo. So kinesin involved in the retrograde cargo. Dynein involved in anterograde cargo, kinesin involved in retrograde cargo. The point which I want you to know is, see, if you have infection with this rabies virus, okay, if you have infection with this rabies virus or polio virus, if this tetanus, Clostridium tetani enter into your body and it is producing a toxin called as tetanus toxin. See, these fellows, okay, these guys, they will use this dynein molecule, okay, not here, it's just a typing mistake. They will use kinesin, they will use kinesin and they are getting transported. Now imagine polio, it entered into my body. Now once polio enters into my body, okay, when polio enters into my body, this polio virus, it uses this reverse axonal transport. It uses the reverse axonal transport to enter into the central nervous system. Okay. So the point which I want you to know is simple, sir. Microtubules are the strongest. Microtubules are the strongest. Okay. Microtubules are made up of dynein, kinesin, as well as tubulin. Dynein, kinesin, as well as tubulin. So dynein is involved in the anterograde movement. Kinesin is involved in the retrograde transport. Anterograde transport as well as a retrograde transport. Next, microfilaments. Microfilaments examples. What are the examples of the microfilaments? The examples of the microfilaments include F-actin. F-actin means filamentous actin. So filamentous actin, it's a actin which is present in the muscles. That's a it's the same actin, but not only that, what I'm trying to put into your mind is imagine there is a cell. Imagine there is a cell. Even in the cell, there are these actin molecules, filamentous actin molecules, which are giving the shape and structure of a cell. So these filamentous actin molecules are examples of microfilaments. Okay, microfilaments. And remember this. Oh, it's a timing mistake. Okay, so F-actin molecules are examples of microfilaments. And the last fellow which I want to discuss here, the intermediary filaments. So these intermediary filaments already I have taught you. Intermediary filaments are the most abundant cytoskeletal proteins, and they are examples of static cytoskeleton. Okay, they are examples of a static cytoskeleton. These intermediary filaments are different type. There are different types of intermediary filaments, and different types of intermediary filaments are present in different types of cells. So based on the intermediary filaments, you can actually identify what's the cell type. Okay. Now let me give you a better example. See, intermediary filaments, they are the most abundant cytoskeleton. Keratin is an example of intermediary filament. Keratin. Where this keratin is present? Keratin, intermediary filament, static cytoskeleton. It is present mainly in the epithelial cells. Okay. So keratin is considered as tumor marker. It's a marker for the squamous cell carcinomas. So tell me, what is the marker for the squamous cell carcinoma? The marker for the squamous cell carcinomas are the keratin. Keratin is an example of intermediary filament. Keratin molecules are present in epithelial cells. So for squamous cell carcinomas, which are coming from the epithelial cells, squamous cell carcinomas, the tumor marker is keratin. Done. Next, desmin. Where is this desmin present? Desmin is just like dystrophin. It is also present in the skeletal muscles. Okay, so it acts like a marker of rhabdomyosarcomas. The rhabdomyosarcomas are the cancers of the muscles, right? Skeletal muscles. So what is the tumor marker of rhabdomyosarcoma? Desmin. What is the tumor marker of squamous cell carcinoma? Keratin. Simple. And GFAP, glial fibrillary acidic protein. Okay, glial fibrillary acidic protein. So this GFAP, glial fibrillary acidic protein, is something present in the astrocytes. Is mainly present in the astrocytes. So in astrocytomas, tumors of the astrocytes. In astrocytomas, what is the tumor marker? GFAP, glial fibrillary acidic protein, is a tumor marker in the astrocytomas. And vimentin. Vimentin, yes, again, intermediate filament. Where it is present? It is present in the mesenchymal cells like fibroblast. Okay, so in all the mesenchymal tumors, okay, mesenchymal tumors are the tumors which are originating from the connective tissues, right? So mainly this vimentin, it is present in which connective tissue cell? Fibroblasts. So vimentin is a tumor marker of cancers arising from the mesenchymal cells. So right here, the vimentin, it's a tumor marker for the cancers arising from the connective tissues from the mesenchymal cells. Okay, and last important intermediary filament is lamin. Okay, last. Okay. Oh, what I made? Did I say something wrong? Yeah, dynein retrograde, kinesin anterograde. Yes. Have I said something wrong? Okay. Oh my God. See, when I'm going fast, I made a small mistake. Okay. Yeah. which means you are listening good. Okay, you are paying attention. Yes, dynein, sorry guys, it's my mistake. It's a dynein is the one which helps in. Okay, this is small thing. The concept is one and the same. Okay, let me write it clear here. Dynein. Okay, dynein, it is helping in retrograde. Simple. Okay, yes, you are true. Dynein helps in retrograde. Kinesin helps in anterograde. That's it. The same thing. Retrograde, anterograde. You know it. So who is helping in dynein helps in retrograde transport? Yes, true. And kinesin, it is helping in the anterograde transport. That's a small change which you can make. Now let's come back. Laminin. This lamin, again, it's a intermediary filament. Where it is present? It is present in the nucleus. Now, whenever this lamin, it is mutated. This is integration with the pathology. Whenever this lamin, which is present within the nucleus, okay, it's actually present in the nucleus. Whenever it is mutated, it's going to cause a disease called as a progeria. Okay, so it's going to cause a disease called as progeria. One such example of progeroid syndrome is the Werner syndrome. Okay, Werner syndrome. What is this Werner syndrome? The patients are getting aged very quickly. Okay, premature aging. Okay, yeah, here I have written there is a premature aging. You can have, like, I hope you have already seen such kind of cases. So the point which I want you to know is the lamin is an intermediary protein. It is present in the nucleus. A mutation. Okay, mutation of this lamin is going to cause a progeroid syndromes. One of the example of the progeroid syndrome is the Werner's, where premature aging is happening. So just as a recap, now tell me, keratin is present in the epithelial cells, marker of squamous cell carcinomas. Keratin pearls are the markers of squamous cell carcinomas. Desmin present in the skeletal muscles, marker of rhabdomyosarcomas. GFAP, glial fibrillary acidic protein, is going to be present in the astrocytes, marker of astrocytomas. And vimentin is present in the mesenchymal cells like fibroblasts or the connective tissue cells. So this vimentin is a marker of tumors which are arising from the mesenchymal cells. And the lamin, it is present in the nucleus. Defect of this lamin is going to cause a progeroid syndromes like Werner syndrome, where premature aging is going to be seen. And again I am correcting, dynamin is helping in the retrograde transport, no doubt. Yes, dynein is helping in the retrograde transport, and the retrograde transport is used by the tetanus toxin. Retrograde transport is used by the poliovirus, as well as the tetanus toxin, as well as one more fellow, that is the rabies virus. Okay, now they will use this retrograde transport. Please yeah, here it was very clear. Yeah, dynein. This dynein molecule, this is true. Okay, dynein molecule, yes, helps in the reverse axonal transport or retrograde. Okay, retrograde transport. Yeah, true. Okay, guys. Now let me integrate a few things with the pharmacology. The points which I want you to know is, this is a tubulin. Tubulin is what? It's a tubulin. Is it a part of microtubule? Is it a part of microfilament? Or is it a part of intermediate filament? Tubulin is a part of microtubule, the strongest one. Okay, the strongest one with the bigger diameter is a microtubules, remember. So this is a tubulin. Okay, tubulin, it helps in the mitotic spindle formation. Okay, the tubulin, look here, this one, a tubulin. All these are the tubulin monomers. See, each molecule is a tubulin. Okay, alpha tubulin, beta tubulin, gamma tubulin, different types of tubulins are there. But point is, tubulin, during cell division, you have this mitotic spindle, right? The mitotic spindles, which will separate the chromosomes. So that the mitotic spindle, it is forming with the help of tubulin. So there are these drugs like vinca alkaloids, like vincristin, vinblastin, colchicine, and taxol group of drugs like placitaxel. There are different group of drugs which will inhibit the microtubules. So what are the examples of microtubule formation inhibitors? Microtubule inhibitors include vincristin, vinblastin, and colchicine. Think logically and tell me. Normally, cell division, if you want to have a cell division, there should be mitotic spindle formation. The chromosomes need to be separated. But whenever you use these drugs like vinblastin, vincristin, colchicine, placitaxel, these drugs, what they will do? They are microtubule inhibitors. Whenever the microtubules are getting inhibited, do you think cell division will occur now? Do you think cell division will occur now? No, the cell division is not going to occur now. No, not possible. Whenever there is no cell division, it's going to be good in which conditions? In the treatment of cancers. So these drugs like vincristine, vinblastine as well as paclitaxel, they are used in the treatment of cancers. So remember vincristine, vinblastine, they are examples of anti-cancer drugs. They are microtubule inhibitors. Even the colchicine, okay, colchicine. This colchicine is also microtubule inhibitor used in the treatment of acute gout. Okay, acute gout. Okay, gout because of hyperuricemia, because of accumulation of crystals. Okay, crystals, the uric acid crystals in the joints. Okay, crystalloarthropathy. It's causes the crystalloarthropathy, right? The patient is going to have podagra, the things. Okay. Done, sir. So, with this, intermediate filaments are also completed. Okay, now take a deep breath. Cytoskeleton is also completed. Now, after the cytoskeleton, let's discuss about one more important topic, which is the cellular fluids. Okay. Now, let's discuss about the cellular fluids. In the cellular fluid topic, for your exam, I'm just teaching for the exam going batch. Before going to the exam, at least what you should know, right? How much water? Okay, imagine I'm an adult male. Out of my body weight, how much percent is actually water? Okay, 60% of my total body weight. Okay, if I am 75 kilos, 60% of that is going to be water. So 60% of the total body weight. That is, for example, if you take adult as a 70 kilograms. Okay, imagine I'm a 70 kilogram. Definitely, I'm not 70 kilograms. Anyway, I'm a little overweight. But if you take an adult male as 70 kilograms, out of 70, 60% is 42. Okay, so 60% of the total body weight is water. That is 42 liters. This is a little different for males as well as females. Adult males, yes, 60% of the total body weight is water. But in females, when compared to what, females are little obese, like they are having little bit more adipose tissue, okay, in the breast tissue, in the abdomen, in the buttocks. Females are having more fat when compared to males. Okay, so in females, as there is extra fat, the water, like quota is coming down. Okay, so the females have 50% of water. Okay, in the total body weight, 50% of it means female is a 50% water, 50% of the remaining. Okay, half of the female is water in the simple way, but 60% of the male is water. Okay, next, children. In children, this is little different. Children, 75% of the children are nothing but the water. If you have a child, 75% of that baby is water only. So male 60%, female 50%, and 75% of the children, their total body weight is water. Next, sir, you already know total body weight, total body water is 42 liters. Now let's divide the entire total body waters into two parts. Okay, see, total body water is 42 liters. If we divide the entire water which is present in the body into two major things, that's the intracellular water, like the fluid which is present within the cells in the form of cytoplasm. Okay, in the cell cytoplasm is there. No, that's also water. You should consider it as a water. The total body water is mainly divided into two types. Okay, that is the intracellular fluid as well as the extracellular fluid. Intracellular as well as extracellular means within the cells, outside the cells. Within the cells is the cytoplasm. Outside the cells is the extracellular fluid. Now question is, who is more? Intracellular fluid is more or extracellular fluid is more? Sir, intracellular fluid, it is 2/3. Okay, most of the students will think extracellular fluid. Sir, extracellular fluid is plasma. No, so much plasma is there, so much blood is there. So extracellular fluid is more. No, intracellular fluids. Okay, intracellular fluid is more, sir. Okay, intracellular fluid is more, 28 liters. Okay, 28 liters. Out of this 42, out of the 42, that is 2/3. Okay, 2/3, that is 28 liters is intracellular fluid. Then how much is extracellular fluid? Extracellular fluid is only 1/3. Okay, so extracellular fluid, it is 1/3. How much is 1/3? 14. Okay, 14 liters. So now tell me, total body water is 42 liters. In a male, I'm talking about a male. Okay, in male, 42 liters. In this 42 liters, how much is intracellular? Sir, intracellular is 28. That is within the cytoplasm, within the cells, and extracellular, outside the cell. Extracellular is just 14 liters. 14, 14, 14. 14 plus 14, 28. 28 plus 14 is 42. Simple. Done, sir. Now let's divide this extracellular fluid. Okay, extracellular fluid into different parts. Outside the cell, where do we have fluid? You know, plasma, you know this one thing, plasma. But in between the cells, imagine there is this one cell, there is this one other cell. Inside the cell there is intracellular water, okay, intracellular. But in between the cells also there is little amount of fluid present. That is called as interstitial fluid. Okay, interstitial fluid is the major extracellular fluid. Remember, it is not the plasma again. Plasma is just only 1/4. Extracellular fluids are divided into interstitial fluid, which means the fluid which is present between the cells. So interstitial fluid, okay, as well as the plasma. Interstitial fluid as well as the plasma. Okay. So how much is the interstitial fluid? Interstitial fluid is 3/4, sir. 3/4. Now just think logically, man. Just think logically. Say extracellular fluid. How much total? Arre, extracellular fluid is 1/3 of the total body water. 1/3 means 14 liters. Out of this 14 liters, see, now I am dividing the extracellular fluid is divided into interstitial fluid. How much interstitial fluid is 3/4. So out of this 14, 3/4 is the interstitial fluid. Okay, you can just calculate, you can divide it. Okay, plasma is 1/4. Okay, plasma is 1/4. So these are the major things. So now tell me, extracellular fluids, only whatever I am teaching, only concentrate on those. Extracellular fluid is divided into, extracellular fluid, 14 liters, it is divided into interstitial fluid, that is 3/4, and the plasma, which is 1/4. Not only this, there is a special type of fluid which is not coming, actually most of the books it won't consider this transcellular fluid under the extracellular fluid. It's a total separate different entity together, but anyway it is also present outside the cell, right? Okay, let's consider it as an extracellular fluid. See, there is fluid also present in the pericardial cavity. Pericardial cavity, that is called as a pericardial fluid. How much? Almost 50 ml. 50 ml of pericardial fluid is there, MCQ. In between our pleura, between parietal pleura as well as visceral pleura, some amount of fluid is there. That is called as a pleural fluid. 10 to 20 ml will be there. That's also an extracellular fluid outside the cells. Okay, and CSF, MCQ, 150 ml of fluid, CSF. Okay, cerebrospinal fluid, which is not present within the cells but outside the cells. So now what I am trying to put into your mind is, sir, the total body water is divided into intracellular, extracellular. Okay, intracellular is majority. 2/3 are intracellular, 1/3 is extracellular. The extracellular is further divided into interstitial, plasma, as well as a transcellular. Out of this, who is the major one? Is the interstitial fluid. Okay, so 3/4 is the interstitial fluid. 1/4 is the plasma. Okay, there is some amount of transcellular fluid which is present in some body cavities. That's it. After this, what you should know is how to calculate the total body water. How to calculate it, man? Like, all these things are for physiologists only. Like, when they are doing experiments, as a doctors, you don't need to know all these things. As a doctors in your clinical practice, it won't help you. But physiologists, while they are doing experiments, conducting experiments, then these things are important. How to measure the total body water is, there is a method called as indicator dilution principle or Stewart-Hamilton method. Okay, there is a method called as Stewart-Hamilton method. Like, so it works on indicator dilution principle. Okay, which means you are going to inject an indicator, and based on how much it is getting diluted, you can estimate. So now tell me, total body water is going to be measured with which method? Stewart-Hamilton method. Stewart-Hamilton method is going to work on which principle? Indicator dilution principle. Now, there are different body fluids, right? Intracellular, extracellular, transcellular fluid, interstitial fluid, plasma, so many things are there. So there are different indicators which are used to measure different compartments. For example, if you want to measure the total body water, then what is the indicator used? Deuterium oxide, MCQ. Many times was asked in PG exams. So deuterium oxide is the best indicator to measure the total body water. Like, if you want to measure the extracellular fluid outside the cells, extracellular fluid, then the indicators are going to be inulin, mannitol, and sucrose. Inulin, mannitol, sucrose are the indicators of the extracellular fluid. Indicators of the plasma, the best indicators are radio-labeled albumin and Evans blue dye. So radio-labeled albumin or Evans blue dye, they are the indicators for measuring the plasma and blood volume. Okay, not the total body water. Total body water is the deuterium oxide. Blood volume, how much is the blood volume? 4 liters, 5 liters, 6 liters, something like that. So blood volume is going to be measured with the chromium tagged RBCs. Now it is used as an indicator. Okay, as a doctor, no, like you will never going to have these things in your life, but for exam purpose you should know this indicators. What they will measure? Chromium tagged RBCs are going to measure the blood volume. Radio labeled albumin is going to measure the plasma, and deuterium oxide used to measure the total body water. So these are the different indicators measuring the different volumes. After this, what else you should know is, in one of the exam, in the recent exam, this question was asked. Blood volume. They will give you certain values in the question and they will ask you to calculate the blood volume. How to calculate the blood volume? What is the formula? The formula for calculating the blood volume is, in the question definitely they will mention you plasma. How much is the plasma? 3 liters, 4 liters, they will give you the plasma. Okay. So, plasma divided by plasma divided by 1 minus hematocrit. Plasma divided by 1 minus hematocrit is a plasma divided by 1 minus hematocrit is the formula to calculate the blood volume. So blood volume is calculated by this formula, MCQ. Okay, hematocrit value also they will give you hematocrit 40%, 30% or 50%. Okay, percent means, for example, if it is 50%, 0.5, 1 minus 0.5, you can take something like that. Okay, so plasma value they will give you, hematocrit value they will give you. So plasma divided by 1 minus hematocrit will tell you the blood volume. But what is the indicator used to measure the blood volume? The indicator is chromium tagged RBCs. Don't forget. Okay. Now, one more important question. With aging from birth, imagine there is a baby. Okay. Time passing. 1 year, 2 year, 3 year, 4 year, 5 years, something like that. With increasing in age, which fluids will increase, which fluids will decrease? Which body fluids will increase, which body fluids will decrease? Is, you should know that with age, total body water will actually decrease, extracellular fluid will decrease, but intracellular fluid is the one which increases, MCQ. Okay, with aging. Okay, while you're coming into the adult, from birth to adult, with aging, total body water decreases. Simple, no, in the baby I have already taught you 75% of the baby is water. So total body water will gradually come down when you age. Okay, so total body water decreases, extracellular fluids decreases, but intracellular fluids increases with aging. Next, there is something important at 3 months. At 3 months, 3 to 4 months, okay, 3 to 4 months, when you check extracellular fluid and intracellular fluid, normally extracellular fluid and intracellular fluid, they are not the same things. Who is more? Intracellular fluids are more than compared to the extracellular fluids. That's what I have already taught you. Okay, here I have taught you the extracellular fluids are less than the intracellular fluids. I have taught you intracellular fluids are more when compared to the extracellular fluids. But at what time in the life? At what time in the life the extracellular fluids and intracellular fluids are equal in 1:1 composition is 3 to 4 months. At 3 to 4 months, the extracellular and intracellular fluids are going to be equal in composition. Okay, so with this, the total body water topic is also completed. Guys, there is a 1 hour topic which is still left. That's a nerve physiology as well as a muscle physiology. 1 hour 15 minutes topic is still left. I don't know the reason why I'm feeling a little throat pain. Actually, yesterday I cancelled the class because of this throat pain only. It's a little hurting me. So let me complete the next 1.5 hour topic. That's a nerve physiology and muscle physiology in the next class. Most probably I will take the class tomorrow evening. That 1 hour 15 minutes class will be there. With that, the entire general topics and general physiology topics will be completed. Okay guys, hope you like the session. Guys, if you have any doubts, you can message me. Is it okay? Okay, the PDF will be shared in the group. Okay, guys, see you for today. See you tomorrow. Thank you. Good night.